Randy, thank you very much for that really lovely and undeserved introduction. But the important element in this respect is that I've had the great privilege to be associated with public health giants, both those who are recognized and those who are not so highly recognized throughout the course of my career. And I'm here today because of Dr. Randy Wyckoff. I'm not here only because he invited me. Of course, that was the reason I came, but also because Randy is one of those people who he succeeded me in my role as the head of the Office of Disease Prevention and Health Promotion. And it's easy to start something in some way. That's the easiest part. What's really hard is the stewardship to continue and grow and make and improve the kinds of initiatives that just happen to be started by some person or another. And Randy, whether it was work at the FDA or his work at the local level or his work at the national level or his work in Congress, for that matter, has been one of those individuals who has improved every place he's ever been in a very substantial fashion. So the thanks really go to you, Randy, for your leadership. It's also a privilege to be here in association with the many others who have been, over the last 9 years, part of the Voices series. And as I looked down the list, I felt not only humbled, but I also felt a warm glow because I know a lot of these folks pretty well. Reed Tuxon, Rich Carmona, Harrison Spencer, David Satcher, Gail Walensky, Jim Curran, David Kessler, Bob Lawrence, Nikki Lurie. I mean, the list goes on and on. I really felt it was really wonderful to be invited, but it would have been even more wonderful if they'd all been here and we could have a collective party. In fact, a couple of the Tennesseans, Bill Frist and John Dreisner, are incredible national leaders in many ways, and who I've had the opportunity to learn a lot from at different points in time. So I'm very grateful and privileged to be part of this series. I was in Tennessee, in fact, in September at the invitation of the governor and John, and had the opportunity to not only see but to feel firsthand the kind of dynamic leadership that is resident throughout the state of Tennessee. And for those of us who have had the good fortune of being involved early, in at least in a contemporary sense, in public health ventures, what is really extraordinarily encouraging is to see that public health is no longer clearly pigeonholed in one little aspect of our health armamentarium. Public health is now infused throughout the corpus of our communities and is fundamentally recognized as a part and the core of what needs to happen to improve the health of populations. And what makes that so encouraging is that in order for progress to come to the benefit of the citizenry, there has to be appreciation across the board throughout our communities. And all we need now, is the strategic insight that each of you will bring and the strategic commitment that each of you will bring to make a difference. So again, thanks for the invitation and thanks for what you do. My title is a conversation on measuring what matters most. So let's first talk with each other a little bit about what matters most. And I'm going to make it easy for you. I'm going to show you what matters most. Here it is. That's pretty obvious, right? That's what matters most. So, 2.9, 17.4, 9,255, 50, 37, 3.5. You're getting the swing of this, right? Becoming clearer. 85, 30, 43, 177, 1/3, 70,000, 40, 1,000, and 3 to 20. That's what matters most. Now, who's going to help me fill in the blanks here? Don't be shy. Somebody just take a guess. Oh, there's one right there. Which one? You forgot? Okay. We'll come back to you. Think again. Look at those numbers. Some of them you've seen. Let's just take that top one. What do you think that might be? Okay, I'm going to give you another little hint. What matters most? Now, is that a little easier? 2.9 trillion, 17.4%, $9,255. 50%, number 37, 3.5%. You recognize these numbers, right? 85%, 30%, 43%, 177 billion. 1/3, 70,000, 40, 1,000, 3 to 20 times. Okay, guesses?
Healthcare expenditure.
Okay, there we go. Right, 1 for 1. $2.9 trillion spent on healthcare in 2013. It's now a little over $3 trillion if you update the numbers. Yes?
Percent of GDP?
Percent of which one?
Second one.
Yeah, 17.4%. 17.4% is the share of our gross domestic product that we spend on healthcare in this country. Another one? You guys are on a roll. You're 2 for 2. Yes?
Per capita expenditure.
That's right. What's that all total up to? $9,255. It's now a little over $10,000 spent every year for every man, woman, and child in this country for health care. $10,000 a pop. 3 for 3. Come on. Perfect record is we got to have a little variety here.
Skip around.
Yeah, you skip around anywhere you want. Go to the bottom if you want.
Is 37 the U.S. ranking?
There you go. 4 for 4. Number 37 is where we rank in terms of our quality of health care throughout the country, if you look at the comparative statistics developed by the World Health Organization. Randy, you told me that there'd be a little variety in this audience, but they're ringers. They're 4 for 4. Okay, come on, keep going. Don't be shy. Somebody has to have I'm going to start calling on you.
177 billion must be the amount that we spend on public health and population-based services?
No, but I'm glad you pointed to that figure because that's one of the more interesting and one of the least reliable figures up here. Most of these are very solid. The $177 billion is up there because it's only from one study, so I have to caveat it. But it's interesting in the following sense. It represents the amount of money spent, actually about 10 years ago in 1 year, on treatment of problems related to use of pharmaceuticals, $177 billion. And the reason that's interesting is because that was more than was spent to buy those pharmaceuticals in that year in the first place. But I'll also move us to another point about the amount of money spent on public health and prevention. Isn't that what you were thinking it might be? That's 3.5%. That's the percent of our healthcare expenditures that go to public health and prevention. let's have just two more points of view, and then we'll move to the full set of answers. So we can't move until we have two more guesses. In the back?
85% spent on your last 3 months of your lifetime.
85%. Right there. Is that what you were saying?
Yes, sir.
Spent on the last 3 months of life? No, that's actually, but it's an accurate general point in that respect, because 85% is the share of early deaths which are due to factors outside medical care. So in other words, if we spent not 17% of our GDP on health care, but 100%, we'd only be able to affect about 15% of the early deaths that occur. We have to look elsewhere for the solutions to our dilemma. Okay, one more. Who's going to be brave and step up?
It's 50% the one that's the last part of life, the expenditures.
Well, that's actually getting closer to the right number on that count. But 50% in this case is actually the amount we spend proportionately per capita for our overall health care than the number two leading leading spendthrift in the world. Switzerland spends about 50% less than we do for health care. All of the European Union nations as a whole spend half as much as we do on average, and yet their track records are much stronger than our number 37 in the world. So let's just go to the rest and then get on through it. What matters most? We've already gone through the 2.9 trillion total, 17% of GDP devoted to health, 9,000 per capita, 50% higher expenditures than the number two globally, 37 health quality, 3.5% investment in prevention and public health services, 85% early deaths due to factors outside better medical care, 30%, this should give us all some concern, 30% of healthcare spending is wasted. And that's a pretty solid figure. And the reason I say it's solid is because I spent a lot of time looking at it. We actually, during the healthcare reform debate in 2009, we did a major review of unnecessary health expenses, and we built our estimates from the bottom up. That is to say, we looked at the unnecessary expenditures in 5 domains. Unnecessary services, services delivered inefficiently, services for which the administrative costs were too high, services for which the prices were too high, and missed prevention opportunities. Looking at all of those domains, and the last one was fraud, those 6 domains, and then building up using the conservative estimates from each of those domains. And the total that we found was $960 billion out of the 2.9 trillion. So that's just one estimate, although a very carefully constructed one. So we thought, let's do some sensitivity testing here. And we took the OECD expenditures as a whole and contrasted the OECD expenditures to our expenditures, and what was the difference? $970 billion. Then we took a third approach and took the Dartmouth estimates, which were looking at Medicare data and ramping them up to national level expenditure. They look at the differences in the costs of care regionally and for the same health outcome. And if you take their estimates, ramp them up nationally, they total to $950 billion. So 960, 965, 950, that's pretty close with completely different approaches to the estimates. This is a lot of wastage for our nation to be losing when we have so many pressing problems around the country. 43% report cost barriers to receiving needed care, the $177 billion we went through. 1/3 of hospitalized patients are hurt during their stay in some fashion. 70,000 deaths per year due to medical error. Actually, this is from our IOM report, which is now 15 years old, and it is unfortunately higher than this. 40 wrong site surgeries per week. This is stunning to me. I have to put a little caveat on this one because it's one person's data point, but that person happens to be the head of the Joint Commission, who has a pretty good sense of how many wrong sites. But can you believe that? 40 wrong site surgeries per week, 1,000 variables per count. This is a very important one. How many of you took Psych 1A? Not fair share. Okay. Do you remember from your Psych 1A course how many variables or numbers an individual can keep in mind after looking at a list? One, it can recite 150 back? That's not going to work. 3, it's somewhere between 3 and 150. It's 7. It is 7. You're right. 7 variables. Okay, so let's say you're a clinician and you can remember, you can juggle 7 different things any one time. You can retain them. Well, what if you had to deal with 1,000? And when you look at the trend line, I'll use this because of genomics and proteomics, for the number of issues that have to be borne in mind by an individual clinician. Over time. So here, let's just say we're down here at around 6 or 7. That would have been back in about 1955 that a clinician would have to bear in mind. Now, it's gone up, and it's over 1,000 right now. The fact is that a single individual working only with their neuronal knowledge base can't possibly have all the information necessary. We have to do things in a very different fashion. 3 to 20 times service variation by geography. This is, again, from the Dartmouth data that indicate that for the same health outcome, and the intensity of service intervention for a particular condition varies by a factor of 3 to 20-fold. Same health outcome. That's part of the reason we have this 30% wasted. Okay, I've spent more time on this than I intended to, but it is a reflection of the challenges that we have in this nation. What does matter? And what matters most, ultimately, Randy would tell you this in an instant, as would many of the people in this room. What matters most is actually healthy people, high quality care, affordable care, and engaged people. Now you'll recognize this as something that has been called the triple aim by Don Berwick and IHI, healthy people, high quality care, affordable care. It's the triple aim plus 1, because we're learning more and more about how we simply cannot make the progress that we need without leadership from you and me and our family members, both in individual health and in community-wide health improvement. That's why the notion that we as a citizenry are becoming more attuned to the fact that we have to be engaged to make a difference, and why this is so important. And what we need to measure are the most essential elements in these 4 domains. And we need to have them reliably and consistently measured across the country. So the basic starting points in considering measuring what matters most is that the measures ought to be basic at the core, tailored at the margin, and provide continuous learning milestones for improvement throughout the system and its components. It needs to be tight, narrow, focused at the core, with tailoring for individual conditions, not just random scattershot measurement because we can measure it. And the reason I put it that way, you'll see in just a minute. Our current profile is a growing burden and expense of measurement requirements. We heard this afternoon from our when we had a session with colleagues from the two largest health systems here. I think this is the Mountain States ballroom, as a matter of fact. One of them was Mountain States, about the number of requirements that they have to report on just in clinical care. And I'm going to talk a little more about that in a second. Unfortunately, this is trending in a direction opposite of the science. Now, what do I mean by that? What I mean by that is that science is more and more telling us about the importance of an integrative approach to the way we deal with our health strategies. And yet our measurement activities are distributive. They're becoming disintegrated in many ways. We are measuring micro-performance rather than system performance. And this is what the focus needs to be on. We're producing data points, and frankly, some of them are more reliable data points, but many of them aren't, because we do better. But given the unsystematic use to which they're put, we're not generating knowledge or evidence. They're not comparable, they're not sustained, they're just numbers in many cases. So imagine instead that we had a measurement system of measures that are finite and focused, aimed at the most important issues, always standardized and harmonized for learning, providing evidence, not anecdote, offering early warning and long-term learning, assessing systems and not silos, collected routinely where most convenient, applied at national, state, city, and healthcare organization levels. That is the same set of measures applied at each level. A necessary but not sufficient set for everything, but fundamentally core, and changing systematically, not serendipitously. That's our vision of what ought to be. And frankly, it can be if we have the collective will and can marshal the policy incentives to make it happen. That was the charge to this report, a report of the Institute of Medicine. We're now the National Academy of Medicine. Vital signs, core metrics for health and healthcare progress. This is a report issued last year, and I'm going to go quickly through how that report provides measures for healthy people, high-quality care, affordable care, and engaged people. And what I'm going to talk with you about in the next few minutes is a sketch of the problem, and literally a sketch, a vital signs solution to the problem, what's proposed by the committee that produced vital signs, what we need to do to refine the measures, and how we take them to scale. So, first, a sketch of the problem. I've already mentioned what the problem was at some level. It's too many measures that are too randomly identified, and here's the problem. This column is measures in use. This column is the measure categories, that is, the different targets for the various measures. And for many of these targets, there are multiple measures. So here, we have, you're not going to be able to read this, obviously. That's why I said it was a sketch. You'll get the gestalt. We have thousands of measures across the general categories of clinical care, population health, costs of health care, and engagement. And what you see in green here, this is a blowout of the measures that are focused only on patient safety in clinical care. Very important issue, but look at the many ways in which they're measuring. And frankly, all of these measures are only targeting about a dozen different issues in patient safety. So why are we doing it in this inconsistent, incompatible way? That's a pretty basic question, but we are, so that has to change. And that's the fundamental aim of vital signs, is to find the most important elements in each of these targets in those 4 areas and rivet the nation's focus on those issues. So the solution that Vital Signs has proposed is essentially this. Here we have the measures in use, which are derived by taking these individual categories and measuring them in many, many different ways. And what we need to do instead is taking these categories and drive the focus on what's really fundamentally most important. By assessing the impact, looking at the quality, at the extent to which their measures are sensitive to outcomes and sensitive to system-wide impacts. And the committee identified 15 issues that are fundamentally important to all of us everywhere, all the time. And they recommended that the nation at every level focus on issues, life expectancy, well-being, overweight and obesity, addictive behavior, unintended pregnancy, healthy communities, and preventive services. These are the population health targets, the healthy people targets. Care access, patient safety, evidence-based care, care match with patient goals as the healthcare quality targets, and personal spending burden, population spending burden as the economic targets, individual engagement, and community engagement. Now you see right away that some of these we can take off the shelf. They're available. But some of them have to be developed as composites, out of component key elements. And that's our task now. And I'm going to talk a little bit about that as we move forward. So here we have the vital signs wheel, if you will. Here are the measures of life expectancy and so forth in healthy people. Here are the measures in quality of care. Here are the measures in affordable care, and here are measures for engaged people. And here is how they relate to available measures in the views of the committee. Here we go with the core measure categories. The key elements that the core measures are trying to assess. For example, healthy behaviors is overweight and obesity, addictive behaviors and unintended pregnancy. And here are the major domains involved. And here, in this column, are the best current measures. Now, I'm not going to go through all of these. I'm only going to reinforce what I said earlier, and that is that for some of these issues, life expectancy, there is a single measure that can be used, life expectancy of birth. Well-being, on the other hand, you could say is a composite of several different things, but in fact, there is a very good proxy, and that is self-reported health, which gives a very good indication of an individual's sense of well-being. What clearly needs to have composite measures developed is healthy communities and evidence-based care, because there are many, many elements that go into both of those. But nonetheless, despite there are many elements, a tightly set half dozen or so can give you a very good sense of how the system is performing with respect to healthy communities. The proxy here that was chosen by the committee was high school graduation rate, but there are a number of other issues as well, childhood poverty, that could be identified. And that's where we need to move now to actually fill in the elements of the composites for some of those that need composites. And evidence-based care is probably the most complicated. The proxy that the committee chose was preventable hospitalizations. But the issue here, there are two issues here that are important as we think about moving forward. One is that the nature of the composite measure that is identified has to be developed by the stakeholder community. It can't be declared by a single group from afar. But there are a finite number of stakeholder communities. For example, if you are running a rehabilitation center, your indices for evidence-based care are going to be a different half dozen than if you're running a cardiovascular center or if you're running a general healthcare delivery setting. But the fact is that ultimately, using a relatively finite, certainly not thousands and certainly not hundreds of measures, we can come up with a set that will actually represent a tight set of measures in the dozens that can be collected up and down the line from the individual healthcare organization level all the way up to the national level, and give us not only a good measure of system performance, but give us a legacy of a research and knowledge generation utility that is unparalleled. When you have standardized data collected on a few tight dimensions that matter most, the potential to generate new evidence and new knowledge is stunning. So refining the measures, the next steps involved are there's an important role for the Health and Human Services Secretary to designate leadership focus to learn from doing, from trial implementation, for simple measures standardized nationally, for composites, undertake a stratified stakeholder development, and for evidence-based care composite, tailoring that to the care focus, tailor to age as necessary, implement a standing capacity and process for assessing the lessons learned and the impact, overseeing adaptation and revision process. That's not an impossible number of steps to take on. It's an entirely doable task. This just shows the related priority measures that are already available, and you see a half dozen or so for evidence-based care, but it's just an indication the committee thought should be given so that the practical reality might be seen by all. And so here's where we are now. We have the core measures, and we need to identify and standardize the tens or so of the discrete categories. And you see in the patient safety, again in green, the notion that the committee teed up as a possibility was that a given system could get a very solid indication of the level of patient safety at every level by just looking at wrong site surgery, hospital-acquired infections, pressure ulcers, and medication reconciliation. Those are pretty straightforward measures. They're easy to accomplish in any setting. So taking to scale, I'm actually not going to go through this in any detail. I'm just going to note that the key element is for healthcare organizations, local areas, state, private payers, and HHS to begin experimenting with the application of these core measures, and also to set up the leadership capacity to refine over the next 18 months the refinements that are necessary with a stakeholder effort, and then move them into action. I'm going to stop here now, although I have a couple of more slides, but I want to have some time for conversation. I'll only say that, again, referring to the conversation that we had earlier this afternoon with a small group of your community health leaders, I had the great good fortune to learn a bit more about the kind of initiative that is in play already here in East Tennessee, and how this kind of tool can be useful to that initiative. But even more importantly, I had the privilege of seeing and understanding how the kind of initiative that you're undertaking here in East Tennessee can be a fundamentally important tool, provide fundamentally important vision and leadership to foster the kind of change that we need throughout the nation. So thank you both for the opportunity to be here with you and to learn from you in the course of my time here. Thanks very much.
Some questions, but I'll start with one, Michael. I'm sure it's something you've heard a lot, and that is 15 measures or 200 measures. It takes us so long to get these numbers. We don't see obesity rates reported for 3.5 years. We don't see infant mortality rates reported for a couple of years. It's beyond the time frame of looking for action and intervention and response. Was there any talk about how we can speed up getting these measures?
Absolutely. In fact, it's feasible to do this once we have. Let's say what we need is ultimately 50 measures in order to make up those 15, and we have the protocols in place to standardize and harmonize those 50 measures up and down the line. They can be easily built into an electronic health record. If the vendors just all built them consistently, the standard set of measures into the electronic health record. And so you have, for example, from this community, let's say that one of your composite elements of community health is high school graduation rate. You have that from other sources. It's not as if the healthcare system has to gather it. All they have to do is put it into the system. So literally putting 15 or 50 data points into the electronic health record, you could, with the press of a button, have real-time assessment, not only locally, but nationally for the state of play. It is not rocket science.
Well, yeah, and I always say, you can go to Japan and get GM stock in real time. I mean, data can be generated immediately. We just have never done it in health.
I didn't. This is a variation on a broader theme that is one of my personal foci, and the focus of the National Academy of Medicine is building a continuous learning health system, which now, unlike 15 years ago when we did Crossing the Quality Chasm and To Err is Human, now is clearly feasible with the digital infrastructure we have, with the new research paradigms, with the new tools for applying what we've learned. We just need to have the determination to make it happen.
Hello.
Hi. Did you remember your question?
I remember it. I have it written down so I wouldn't
Okay.
forget. Well, we in America pretty much have a huge pharmaceutical industry, and so it seems like our culture is geared more toward medicine as a solution rather than a tool. It makes sense why preventative care gets pushed to the back seat. You take a pill and everything's supposed to be fine. We expect medicine to solve our problems, but I don't want it to be public health versus pharma. So how could we work together to switch gears with pharmaceutical industry to kind of put these into play? Because it seems like we're doing the opposite of what they would want us to do.
Right. Well, I like your attitude, the attitude of this is not a we, they. In some cases it is, but some cases it's not. We need to find a way to work together to draw the resources, which are substantial within the community as well as within different companies, not just pharma companies, device companies, insurance companies, a variety of private sector leaders who, individuals want to do the right thing. And the way the incentives are structured often push us in a direction that isn't the most productive for society. So we have to have not only communication, but a change in the incentives. And one of the things that we were talking about earlier was the notion of shifting the payment models that we use away from fee for volume, that is individual services, to fee for value, that is the overall outcome for an individual and for a community. And the Centers for Medicare and Medicaid Services is working hard right now to try to develop payment models that will move the incentives for payment to population-wide health improvement. That in itself will drive the use of medical interventions into more appropriate circumstances. And the other dimension of that that's very important is that in order for that approach to work, transparency is critical. There has to be transparency on costs and outcomes throughout all parts of the system. You know, it's very interesting when you hear debates on healthcare reform, certain elements of the participants in the debate are interested in saying that what we need is a free market system or a system that doesn't put regulatory constraints too much on. But the fact is, you all know, just like you took Psychology 1A, you took Econ 1A, that for a market to work, you have to have perfect information. And we have a market that has about the most imperfect information that one can imagine. So transparency is obviously key.
You've described the 4 domains in your model. Where is accessibility? Accessibility,
it's throughout, but obviously there's a fundamental need for access to quality care, and that is an explicit component. But there are also an implicit component of accessibility to the broader population health efforts, and even to the issue of engagement. Health literacy, for example, is a great barrier to accessibility to engagement. And the same is true for the cost dimensions. Until we have better transparency on the cost components of care, we're going to have very little capacity to change our demand function for the kinds of care that costs less and delivers more value.
Hello.
Hi.
Hey, I'm a physician. I work in the hospital. And the thing is, the patient population we are seeing right now, lot of the health, as a community, the health problem is lot of it is psychiatric. And when you talk about community health, families are very nuclear. There's no social support system. The way the society is heading, if a patient is diagnosed with something terminal, everything crashes down, he thinks pill is the solution. How are we gonna support and build up the community so that they support each other? Is there a way? Because pill is not the answer for everything.
A pill is not the answer for everything. I think we could leave it at that. But you've pointed to one of the other reasons for our need to focus on a core set of what's most important. So you see the proxy here in community engagement is social support. Mm-hmm. We need to know for every patient what their level of social support is. This needs to be transparent as well, so that we can sensitize ourselves as providers to the kinds of needs that are outside an individual pill. And I think that to pick up on a point that I referenced earlier about the Centers for Medicare and Medicaid Services interested in developing a reimbursement approach that is based on population-wide health improvement. If they're going to be effective in that respect, they have to know how to measure social support and community engagement. So again, it's very important that we look at what matters most and develop the capacity to have those indices up and down the line.
I'm also a physician in training. One of the questions that I had, so we rotate through both Mountain States, Wellmont, and then also the VA systems here. to see this a very similar patient with a very similar diagnosis, it can take a dramatically different course of time depending on which electronic health record we interact with. So, something that can take 15 minutes on a paper chart may take 50 minutes by the time you're done putting in electronic orders, et cetera. If the system crashes, you have paper things to go through and all that. Where are we on a public health level in terms of somewhat standardizing some of those electronic health records? Because that's a huge.
I think if you were to ask me what are the two most important changes needed in healthcare right now, healthcare specifically, I would probably say, and they're related, the issue of transparency and the issue of interoperability of healthcare records. And we in the National Academy of Medicine are going to be spending more attention on that issue. And in fact, it came up indirectly in our earlier conversation this afternoon when we were talking with two systems who have incompatible health records. And the question in my mind, and a number of others, is since healthcare delivery systems are the first line of any effort to create interoperability, isn't there a way that we can develop a network of the leaders of those systems to come to agreement on the features of any system that they purchase? Where there are a variety of ways to approach this. One is the regulatory system and develop a slavish down the line set of regulations. That's better than nothing in some ways, but better still would be to develop a set of principles without whose fulfillment there would be no purchase in order to drive that interoperability. I've gone too much into the weeds in this case, but the fact is it is a fundamentally important issue. We will fix this, but it's not necessarily going to happen tomorrow. I want to just come back to one issue that you mentioned that I crossed my mind that I think is important to emphasize, and that is you indicated the behavioral health problems, that mental health and substance abuse problems. This is another issue that has to be changed dramatically. In other words, our approach of carving out these services and sort of putting them off in some other place, disintegrating them from the broader healthcare delivery system, is eroding everything. By that I mean it's not only eroding the quality of care, even the possibility of care for the patients involved, but it's undermining the ability of larger healthcare delivery systems to do their job. When you have a system, and we were mentioning earlier in my conversation not too long ago with the then president of the American Hospital Association, he underscored the fact that more than half of the patients who are treated by his member organizations have behavioral health problems, but they're just not recognized, and the system is unable to deal with it. So until we get that right, we're not going to be able to make the kind of progress that's necessary.
If we're ranked 37th, what makes the number one ranking? What are they doing differently?
There are a number of issues that are in play there. First is, and I'm making this up, first is that there are clearly very different modes of payment and reimbursement. We do have a fee for service and or fee for volume and not a fee for value approach. If you look at any one of the European countries, and especially those in Scandinavia, which have much higher returns on investment, their approaches are much more focused on the delivery of a broad range of prevention and public health services, along with individual treatment services. The notion of a fragmented delivery system in which every individual service is delivered by a totally disconnected entity is much less of a factor in play. The notion of a culture which has a greater tradition of social consciousness and engagement. The need for integration of social services is much more recognized in the systems that are the top performing system. And the economic incentives that play on the system also play very differently for the providers. The provider incomes or physician incomes are at a different level for the most part. Now we see some changes here occurring in that respect. The dramatic change just in the last decade or so in the shift of people coming out of medical school, for example, not going into private, small, independent practice, but going into employment circumstances, is it's a first step toward a different dynamic in that arena, but it's a step toward what is much more common in those high-performance systems.
Okay, I'm just an undergraduate, so my question probably is not going to be as complex as everyone else's. But I do find that after a conversation such as this one, people my age will leave motivated and they want to make a change, but they'll get home and they have no idea where to start. So how do you recommend as a student to begin making these changes in the minds of what's essentially going to be your future generation?
Oh, gosh. I am so glad you asked that question. No, I really am. Because the first step in empowering yourself as a change agent throughout society and throughout your life is to ask that question. And I suppose my answer would be to go back on my own experience, frankly, and that is just to get out there and do it. Don't just study it. You do want to do well in your courses. Randy would not allow me to say otherwise. But get out there and get the feeling for the community. Get the feeling for the people whose lives you want to change. Get a sense of what makes them tick and what makes their lives either functional or dysfunctional. And when you can feel the forces in play, you will advance your education substantially. I remember when I was an undergraduate, I went to Berkeley as an undergraduate, and I took undergraduate public health. It's called Public Health 5A. And we had this is a very long time ago. In fact, I'm having this year my 50th college reunion. But I spent 2 weeks in Chinatown in San Francisco, knocking on doors in neighborhoods that spoke no English, trying to identify and get into care people who had tuberculosis, which was a huge problem. And you can imagine how, a junior college student accelerated his educational process by getting a first-hand feel for what was in play in those neighborhoods.
Well, that was a great answer, Michael. And though I do wonder, when you took undergraduate public health, since it was in the pre-McGinnis era, what was there to learn?
We learned a lot about germs.
Well, Michael, I can't thank you enough for coming down, for everything you've done. We do have some. As always, when speakers come in like Dr. McGinnis and he leaves at 5 a.m. the next morning, he has a very small carry-on bag, so we always give you a large box of gifts.
Thank you very much.
And then a plaque that designates you as an honorary professor in the College of Public Health here at ETSU.
I am
So thank
honored
you.
indeed.